All right. Hello, hello, hello. Good evening, everyone. I want to welcome you to our Community Health Forum this evening. We are very lucky to have with us some amazing experts and also some amazing elected officials from different levels of government who will be providing a town hall style discussion after our expert presenters. I want to thank our collaborators, Democratic Women of Wake County and the African American Caucus of WCDP. We really do love working together, and we think that tonight's topic and subtopics are particularly timely. We will be discussing two specific subtopics. The first one will be challenges to reproductive health, and the second one will be disparities in access and outcomes for Black maternal health. So it's a really serious, these are really serious, these are existential, and we are just excited that you are here to speak with us. A little bit of housekeeping. We are asking that folks stay muted during the presentations. There will be plenty of time to have a conversation when we get into the breakout room. After we finish with the presentations, we will transition for a moment, and I will ask you all which breakout room you would prefer to go to. So you will raise your hand when I ask if you want to go to this one or if you want to go to that one, and we will move you into those rooms at that time. You will have approximately 30 minutes to speak with the different electeds who will be in there. We have elected officials from the municipal level all the way up to Congress joining us this evening. So we are really excited about that. There will be two moderators in each room to help keep things moving along. Of course, if you have any technical difficulties whatsoever, you can hit me in the chat directly, or Frank, or ask your moderators when it's time to get into those rooms. But otherwise, what I want you to do is sit back, listen, take notes, engage, and then when you get into those town hall forums, really have some thorough discussions. All right, so before we go any further, I want to welcome our two experts, Susanna Birdsong and Darlene Singletary, and I want to welcome our elected officials. We have with us Ann Robati, who is Morrisville Town Council. We have Vicki Adamson, who is on our Wake County Board of Commission. We have two of our House District representatives here this evening, Julie Von Hafen, who is in HD 36, Cynthia Ball, who is in HD 47. We have Sydney Batch from Senate District 17, and she will be here in a few minutes, but Deborah Ross, our Congressional 2 Congresswoman, will be joining us in just a little bit. So without further delay, I'm going to go ahead and roll this over to Ms. Tanyetta Sutton, who is the president of Democratic Women of Wake County. She's going to introduce Susanna Birdsong to you. Tanyetta.
All right. Good evening, everyone. Susanna Birdsong, welcome. Susanna Birdsong is the Director of Public Affairs for Planned Parenthood South Atlantic. She works with a wide variety of elected officials, coalitions, and community partners to advance reproductive freedom and defend against policies that will restrict access to reproductive health care. Before joining Planned Parenthood South Atlantic, Susanna lobbied in North Carolina General Assembly on civil rights and civil liberty issues as a senior policy counsel at the AAC-WCDP of North Carolina. She grew up in Wilkesboro, North Carolina, obtained her bachelor's and master's of social work degree from UNC Chapel Hill. Ms. Birdsong, I love me a social worker. She also earned her law degree from American University's Washington College of Law. Following tonight's expert presentations, there will be two breakout rooms to discuss the topics covered by each elected representative. For challenges for reproductive health, you will have a chance to discuss the information that Ms. Birdsong shared with us tonight in conjunction with our very own elected officials. Wake County Commissioner Vicki Adamson, North Carolina House 49 Representative Cynthia Ball, and North Carolina District 2 Congresswoman Deborah Ross. Once again, Ms. Birdsong, welcome. We thank you for being with us, and now I turn the floor over to you.
Thank you so much, Tanyetta, and so good to be with y'all tonight. I am going to attempt to share my screen. Can y'all see that?
Yes.
Yeah? Okay, great. We are going to be talking for the next few minutes about challenges to reproductive freedom in North Carolina and beyond. And this is a pretty timely topic, as I know y'all know. So just a couple of slides first about who we are at Planned Parenthood and Planned Parenthood Votes South Atlantic. So Planned Parenthood Votes is the advocacy and political arm of Planned Parenthood South Atlantic, which is our organization that operates health centers. We are a multi-state affiliate, and so we operate health centers in North and South Carolina, as well as in Virginia and West Virginia. And in North Carolina, we have 9 health centers across the state, and 6 of those health centers provide abortion care. At Planned Parenthood Votes, we are a nonpartisan organization that engages in mission-centered political advocacy focused on protecting access to patient care. And at Planned Parenthood Votes, we support elected officials when they stand with us and hold them accountable when they oppose reproductive health. And this work takes place in both legislative advocacy settings and electoral settings. And you'll recognize some of your friends in these pictures below. And, you know, the reason that we exist and the reason that we have a political and advocacy arm is because the healthcare that happens in our health centers every day is under attack in the state legislature, depending on who's in charge at the federal level, and in states across the country. And so over time, Planned Parenthood has recognized the need to do more political advocacy to combat those political attacks. Since 2011, this is a trend across the country, but North Carolina is certainly a microcosm of this. Since 2011, we have seen hundreds of abortion restrictions passed in states across the country. And this past legislative session, the one that we are still in North Carolina, has been the worst one yet since 1973, since Roe v. Wade legalized abortion across the country. Legislators are feeling emboldened by a changed US Supreme Court, and more than ever before are really looking to test the limits of Roe v. Wade and restrict access to constitutionally protected abortion care. And North Carolina is, of course, no exception. Since 2011, when we saw a huge change in who was in charge in the General Assembly, we also saw numerous restrictions on access to abortion become law in our state. And those include things like the longest and most draconian waiting period in the country. Someone has to wait in North Carolina 72 hours after they receive state-mandated biased counseling before they can make an appointment and go in and access constitutionally protected health care. We also have laws on the books that do things like say you can't provide medication abortion via telehealth, which has been something that has been really laid bare in the pandemic, sort of the travesty of that, in that we can't even prescribe people a pill over telehealth because people are required to come into the clinics and receive those pills in person by state law. We also have laws on the books that say only doctors can perform abortions, even though we know that other types of healthcare professionals like nurse practitioners and physician's assistants, certified nurse midwives, can perform abortions safely and do perform abortions safely in other states around the country. But we have a law on the books that says only doctors can do that, which really limits access to that care. That care is not available in 91 counties across North Carolina's 100 counties. We only have 9 counties across the state where abortion clinics are located. And so if you live in a rural county, or if you live far away from one of those centers, you're looking at a significant drive time to get there. This picture on this slide is from our sister state to the south in South Carolina. Earlier this legislative session, they passed a 6-week ban, which of course is something that a lot of states all around the country, especially in the South and in the Midwest, are attempting to do at this point, including Texas. And so I know this is something that y'all probably know all about at this point. It has been in the news a lot. Texas passed the bill number, this past legislative session was SB 8, and this was a 6-week ban. So this is a ban on abortion after the 6th week of pregnancy, which is before most people even know that they are pregnant. And this ban was different from the one that South Carolina passed a few months prior, and the ones that every other state has passed to date, in that it said that it's not up to the state to enforce the ban. The ban was going to be enforced by everyday people. Anybody could enforce the ban. You didn't have to live in Texas. You could be anywhere, and you could file a lawsuit saying that someone had aided or abetted an abortion in Texas. And they didn't define what it meant to aid or abet an abortion. And so this could impact your Uber driver who takes you to the clinic. It could impact your minister who counsels you as you're making a decision about what to do with your pregnancy. It could include your family members. It could include your physician. And so this ban, you know, every other ban that has been a 6-week ban or anything close to a 6-week ban has been enjoined by the courts and not allowed to go into effect because it is in clear violation of Roe v. Wade. And so this bill was supposed to become law and take effect on September 1st. And it was the last week of August, and the court hadn't enjoined the law yet. And so Planned Parenthood Federation and many other partners had all filed a lawsuit to challenge the bill. And they took an emergency petition to the Supreme Court and said, you have to block this law. It is about to go into, and it is in clear violation of Roe v. Wade. And on September 1st, when the law was going to take effect, the Supreme Court had not, and they did not weigh in until late that night. The law was allowed to take effect, and they said in a really short order that they were going to allow the law to take effect because they didn't know what to do with this new procedure, where it wasn't the state who was enforcing the law, it was all these other potential people. And that was unprecedented on a number of levels. And what it means effectively today is that abortion is banned in the state of Texas. And that is a direct violation of Roe v. Wade, of the constitutionally protected right to abortion before viability. And, you know, I think it does not bode well for what the future holds for abortion access in this country, at least federal level. So the Supreme Court, you know, all this is happening on this Texas law right now. And, you know, the Department of Justice, the U.S. Department of Justice filed a lawsuit, challenging Texas's passage of this law and saying you can't, as a state, pass a law that is in direct violation of the federal law. And so that case is, you know, proceeding. They just appealed to the U.S. Supreme Court to again block the law. And so we will see what happens. But as it stands right now, it is still in effect, and abortion is banned in Texas. Meanwhile, there's another case out of Mississippi that the Supreme Court will hear oral arguments in on December 1st. In that case, Dobbs versus Jackson Women's Health Organization deals with a 15-week ban. And so, you know, much later than a 6-week ban, but still well before viability, which is the current standard. You know, the states can't place undue burdens in the path of someone trying to access an abortion pre-viability. 15 weeks is way pre-viability. And no one was expecting the court to take this case. The district court had enjoined the law as a clear violation of Roe v. Wade. The Court of Appeals, the Federal Court of Appeals, had had affirmed that injunction, and there was no really question for the Supreme Court to take up. And they took the case, which is ominous. We have seen, 3 Trump appointees appointed and confirmed to the US Supreme Court in the last few years, and that really shifts the balance of the court. And there is not much optimism about what they're going to do when they hear this case. We probably won't know until next June. But at that point, it is very likely that there is an outcome where abortion regulation in large part goes back to the states. And so what that means is that millions of pregnant people in need of abortion care and people who could become pregnant in need of abortion care across the country will lose access to that care almost instantaneously. There are several states across the country that have what are called trigger bans, which is if the Supreme Court overturns Roe v. Wade or says Roe v. Wade is no longer in effect, then we will ban abortion. And those laws will take effect as soon as the Supreme Court rules, and abortion access will be foreclosed in those places. And what does that mean for North Carolina? In North Carolina, we are in a political climate where we have hostile legislative majorities in both chambers of the General Assembly, but we have a pro-reproductive health governor, and we have the ability to sustain his vetoes of any bad bills that the legislature passes in North Carolina at the moment. And I just want to be really clear that although I am not ringing an alarm bell in the same way that I am ringing it in South Carolina or West Virginia right now when it comes to what the impending Supreme Court decision in June will mean for abortion access in North Carolina immediately, I am ringing the alarm bell because it all depends on election outcomes. And if we lose our ability to sustain vetoes in the legislature in the next election cycle, then we are looking at, some dire outcomes in North Carolina. But for the moment, I think we are in a better place than most other Southern states. And I will take that bit of good news, at least for the short term. That's my depressing end of my slides. And I am going to turn it back over to Kevin Creech, who will lead us into the next speaker. Thanks, Kevin.
Thank you so much, Ms. Birdsong. It may be dire, but it's what we need to hear. We need to stay activated, and I'm hopeful that the stakeholders who are in this room this evening will have really good, thorough conversations with the elected officials in the breakout rooms. Moving right along on our theme of health, tonight we are also going to be talking about disparities in Black maternal health access and outcomes. We have an amazing person with us this evening. She lives right here in Wake County, as does Ms. Birdsong. And I'm going to turn this over now to Ms. Nikki Jeffries of the African American Caucus of Wake County. President Jeffries, the floor is yours.
Thank you, and good evening, everyone. Darlene Singletary is tonight's expert on disparities in Black maternal health and outcomes. Darlene is a public health educator who has been in the field for more than 5 years. She received her Bachelor of Science in Health Education with a concentration in community health at North Carolina Central University in 2015, along with a Master's in Public Health from Benedictine University in 2020. Her passion for health education started early as she was a trained peer educator and president of a campus organization that focused on preconception, pregnancy, and parenting. The mission was to address health disparities, minority health, and maternal and child health. After graduation, Darlene continued in the field of maternal and child health by becoming a national certified childbirth educator and birth doula. With this, she has become an advocate for women of color, plus low-income and underserved families. Currently, Ms. Singletary works as a public health educator in maternal and child health for Wake County Health and Human Services. In her role, she co-leads the Best Baby Zone, a community-driven initiative that focuses on addressing infant mortality and health disparities. She also provides education to families regarding pregnancy and childbirth, infant safe sleep, and child passenger safety. Darlene Singletary is trained through the NCDHHS Division of Public Health in SIDS, grief counseling, and provides basic support to parents who have experienced an infant loss due to SIDS or sleep-related injuries. During tonight's town hall sessions, you will have a chance to discuss the information that Ms. Singletary has presented with Morrisville Town Councilor Ann Robati, NC House 36 Representative Julie Von Hafen, and NC Senate 17 Senator Sidney Batch. Welcome, Ms. Singletary. I am turning the floor over to you.
Thank you, Nikki. So what I'm going to do really quickly is share my screen with you all. All right, can everyone see that good?
Yes,
Perfect.
ma'am.
All right, so like she said, my name is Darlene Singletary. I'm one of the public health educators here at Wake County Health and Human Services in their maternal and child health program. And I just want to talk a little bit about some of the disparities that are within the Black and maternal child health realm. So when you start to think about Black maternal and child health, the first question that usually comes to mind is, what is Black maternity mortality? So just to go into that, the World Health Organization defines maternal mortality as a death that occurs during pregnancy, birth, and up to 42 days postpartum. For Black maternal mortality in the United States, it's often referred to as the incident of maternal mortality in the United States for people that identify as Black or African American. As you go into that, you start to think about, well, what are the disparities? So the most common statistic that we often hear is that in the United States, Black women are 3 to 4 times more likely to die from pregnancy-related causes than that of white women. Then when you start to think about mom, you have to think about baby. So within that, a common statistic that's often thrown out is that Black infants are 3 times more likely to die within the first year compared to that of white babies. When looking at some of these leading contributors, the disparities that often come up, or some of those lead disparities, is social determinants of health, which is often a buzzword. And as we know, with social determinants of health, these are conditions in the environment where people live, they're born, they work, they play, they worship, which contributes to a wide variety of their health, their functioning, and the quality of life as it relates to outcomes and risk. So to bring it all into Wake County, one thing I would like to point out is that, for Wake County, it's home to nearly 1 million people. And they're very known for their great achievements, such as public schools, colleges, universities, hospitals, and public health infrastructure. However, there's still a continuum of economic inequities as it relates to racial biases and health disparities. Communities across the county has disproportionate infant mortality rates, especially within lower income communities. And even though there has been multiple efforts to help to address that racial gap and those inequities, the poor birth outcomes still remain. One thing that I want to point out with Wake County is that when you look at it as a county in whole, the median income in 2018 was about $75,000. Of that, 25% of that population had incomes that was 200% under the federal poverty level. However, when you're looking at communities in Wake County, such as like Southeast Raleigh, nearly 70% of those residents have incomes that are 200% under the federal poverty level, making their median income about $30,000 a year. Of that, 75% of the residents are African American or identify as Black. Of those 75%, 25% of that population alone is uninsured. So they fall between that insurance gap where they don't quite meet the measures for Medicaid, but they also can't afford private insurance as well. So outside of economic stability, there are also other factors that we have to take into account, such as the quality of healthcare, structural racism, and implicit bias. So with this slide, I wanted to be very intentional. So if you see the picture here, the young lady her name is Shalon Irving. I wanted to share a little bit of her story just to kind of make it a little more, realistic. So Miss Irving was a lieutenant commander in the U.S. Public Health Service Commission Corps, and she was also an epidemiologist with the CDC. Miss Irving was a person that you would say had access to resources because of her educational level, her professional success, her strong insurance plan, and her supportive network. But as a person working in public health, she had a passion for improving community health. And one of her quotes says that, "I see inequity wherever it exists. I call it by its name and I work to eliminate it." But for Miss Irving, at the young age of 36, she became pregnant, which was something that was very unexpected, but also exciting at the same time. And being a professional that worked in public health, she not only advocated for having a healthy pregnancy, but she also advocated for having a great birth outcome. But just 3 weeks after giving birth to her baby, she died. And the cause of her death was preventable. So for Ms. Irving, she died due to complications for high blood pressure. So in the midst of advocating for herself, but also too for other communities, she still lost her life to something that was preventable. And for her story isn't just one, it's one of many. It's not something that's just happening in Southeast Raleigh. It's not something that's just happening in Wake County. It's happening all over. So when you start to think about Black maternal health, we have to include preventable health complications such as postpartum hemorrhaging, preeclampsia, chronic stress, just to name a few. We also have to consider that a person needs access to health care. And then also too, we have to think about something that a visitor that just came to see us last year, COVID-19. When you start to look at the year 2020, the COVID-19 pandemic shone a lot of light on the disparities that were going on in different communities, especially those that were Black and Brown. The pandemic not only caused disparities within itself, it worsened the ones that were already present. According to the CDC, for new and expectant parents or mothers with the virus, they were 50%, had a 50% higher chance of being admitted to intensive care. And they also had a 70% higher chance of being intubated than non-pregnant women within their childbearing years. The data not only shows that pregnant Latina women as well as Black women were becoming infected, but also too that they were coming infected at a higher rate than that of white women. And I'm sure from that, a lot of you are all thinking like, why? And that just goes back to show those different disparities and those different social determinants of health that I mentioned before. So when you start to think about mom being healthy, you also want to make sure that baby is healthy because those things can spill over. So with maternal and child health, for Wake County, African-American infants born or residing in Wake County are 4 times more likely to die than white babies. African-American women in Wake County have poorer birth outcomes than white and Hispanic women based off of birth weight, gestational age, and the adequacy of prenatal care. As we start to think about this, to end preventable deaths of women and babies, every pregnant woman and newborn needs access to skilled care at birth with evidence-based practices that are delivered in a humane, supportive environment. Good quality of care requires appropriate use of effective clinical and non-clinical interventions. We want to make sure that there's a strengthened health infrastructure and optimum skills and the attitude of the providers, because all of these things result in improving health outcomes and positive experiences, not only for women, but for the providers as well. Quality of care is considered a key component of the right to health and the route of equity and for the dignity of women and children. So when I start to talk about infant mortality, I wanted to show you all some of the rates that have been seen or some of the data that has been collected. So when you look here, you see for 2019, for Wake County, the total infant mortality rate was 5.8. But when you look at it for Black non-Hispanic infants, the rate was 13.0. And then when you look at it for Hispanic babies, it was 6.7. Going back to African American or Black infants, for the entire state, the rate was 12.5. For Wake County alone, it was 13.0. Going into stats about mothers and babies, in 2019, there were over 12,000 births. Of those births, 964 were low birth weight, meaning that the baby was born under 5 pounds, 8 ounces. And from that number, 392 were Black babies and 143 were Hispanic. And then you also can take into account other things that are mentioned here. Mothers that were unmarried, so single family homes. And also too, how soon did they receive prenatal care or education as it related to their pregnancy? Out of the 12,000 births, only 1,500 of those moms were African American and received it within that first trimester, basically meaning those first 13 weeks. As you break down the infant mortality rate, you can look at perinatal deaths, fetal deaths, neonatal deaths, post-neonatal, and then just infant deaths as a whole. What I really wanted to point out is, as I highlighted here for African Americans, is that when you start to look at these numbers of deaths, these numbers are way higher and a huge contributor to the total. Pointing out post-neonatal, there were only 18 deaths. However, 12 of them were African American babies. As you start to think about, well, you know, what's already out there, what services are working or pushing to support families. Being that I'm someone that works in Wake County Health and Human Services, I wanted to highlight the maternal and child health section for the programs that we have and the initiatives that we have. One that I definitely want to talk about is the Best Baby Zone. So the Best Baby Zone is a place-based, multi-sector, community-driven effort that applies what we call the Best Baby Zone approach in a life course perspective. The vision of the BBZ, or the Best Baby Zone, is that all babies are born healthy in a community that enables them to thrive and reach their full potential. To address this vision, we have 4 key strategies. The first one being a zonal focus. So for our zone is Southeast Raleigh. Because one thing that we noticed was that the infant mortality rate for Wake County was 13.0. The infant mortality rate for Southeast Raleigh alone was 11.1. So within our zonal focus, we had to pick an area where there was a minimum of 100 births and had residents between 8,000 to 20,000. The second strategy is making sure that we're multi-sector and that we have collaboration. So we want to share, we want to partner in with things that are already there and strengthen upon those things so that, we can assist with the health system and services, the economic development, education, early childhood education, and all of those things. The third is being community driven. One thing I like to say that the BBZ prides themselves on is going into the community and strengthen on the things that the community already says is working. We don't want to kind of go in and say, you're doing these things wrong, you have to listen to us. We want to listen to them. So that's one of the key strategies. And then the fourth key strategy is cultivating a social movement. So like with the first statistics that I mentioned, it said in the US. So this isn't just a Wake County thing. This is nationally, if not globally. So we're already a part of a social movement that's taking place today. And the BBZ strategy helps to advance local and national equity-focused social movements with the ultimate goal of reducing racial inequities in maternal and also infant mortality. With the Best Baby Zone, this is something that kind of came out of an infant mortality group that our former commissioner convened, where they uncovered the root causes of infant mortality by identifying research-based practices that work, develop specific actions that help to address that gap. And from that, they had a variety of people, clinicians, residents, moms with lived experiences, advocates, human services professionals. And they were able to identify 6 focus areas: home visiting, safe sleep, access to prenatal care, racial equity, fatherhood initiatives, as well as preconception health and women's health. So when you start to think about those things, I'm sure a lot of you are coming to the thought of, well, what can we do? One thing that I've noticed within my research with comparing, north to south, is that Black women that live in the South generally experience poorer birth outcomes, if not just overall health outcomes. And many of these things have to do with the expansion of Medicaid, coverage gaps, and things of that nature. But I really want to charge everyone to start to think about, investing in healthcare safety and the quality of improvement initiatives. We don't have to create something if something's already there. Just build upon and invest into those things that are within the communities already. Also, too, address those social determinants of health. Like I mentioned before, that's a buzzword. Let's make it be something that we can create action from. Also, too, expand and maintain access to health coverage. And lastly, one thing that I always like to say is, be slow to speak, but quick to listen. Listen to what the communities are saying that could be things that are contributing to these poor birth outcomes, that could be contributing to these poor outcomes, health outcomes for mothers. It's very important that we really phone in on what the community is saying, because that's one way that we can bring forth change. And I do want to say thank you to everyone for attending and listening to this. If you do want to reach out to me, I have provided my phone number and my email, and I'm going to hand it back over to you, Kevin Creech.
Hello. Wow, that was eye-opening, and it gives us time to, or makes us want to take time to pause and really think about all the different moving parts in the outcomes, the access that women, particularly Black and brown women, poor women, rural women have with regard to health, and in particular, pregnant people with regard to health and their babies. So thank you so much for that. And I'm looking forward to a robust discussion in our breakout rooms. So what we are getting ready to do in just a moment is to move folks into their breakout rooms of choice. Frank, I'm going to go ahead and have you move our mods and our elected officers in the correct breakout rooms while giving some instructions to our stakeholders here. Here's how this is going to work. We have two breakout rooms. Breakout room 1 is challenges to reproductive choice. Breakout room number 2 is the disparities in Black maternal health access and outcomes. So we will first be moving folks into room 1, and then we'll move folks into room 2, and we'll do this by simple hand raising. Let me tell you who is in room 1 with the challenges to reproductive choice. Our room moderators are Angela Garrett of African American Caucus and Elaine Okal from Wake County Democratic Party. Our elected officers for that room, our elected leaders for that room who will be participating will be Congresswoman Deborah Ross, Representative Ball, and Commissioner Adamson. For room 2, disparities in Black maternal health access and outcomes, our mods are President Tanyetta Sutton from Democratic Women of Wake County, and also Ruth Merkel of Democratic Women of Wake County. Our elected leadership in that particular room will be Senator Batch, Councilwoman Rabati, and Representative Von Hafen. So first things first, if you would like to go into breakout room 1, challenges to